University of Medical Science, working as gynecologic surgeon in Starcare Hospital. Glad to be here, and I want to start my presentation about minimally invasive surgery in gynecology. Nowadays, changing our approach for any surgery to minimally invasive is feasible. Even if we cannot do the surgery completely by laparoscopy, we can use other minimally invasive technique. This way we can benefit from the best view of the laparoscopic surgery, and for the rest of the surgery, for doing something like tissue removal, placing some instrument, or either technical issue, we can do mini laparotomy for the surgery. More than conventional laparoscopy, single port laparoscopy can be done for selected cases like hysterectomy, and the most up-to-date technology is utilizing natural orifice of body. We call V-node surgery. We can use the same technique like single port but from vagina. This technique can be used in selected cases for hysterectomy, for example. Why laparoscopy? Actually, nowadays we can ask this question. Laparoscopy comes with better recovery, shorter hospital stay, less post-operative pain, lower blood loss, and scarless surgery. If we have minimally invasive option, we have to do that. And when we have this option, is based on our experience, appropriate team, and suitable equipment. We have to know our limitation for scheduling the patient for laparoscopic surgery. Laparoscopic surgery needed to at least 4 eyes and 4 experienced hands to done any type of surgery, and a lot of modern equipment. In the field of gynecology, some surgery is preferred to done by laparoscopic, especially for infertility-related surgery, because of the importance of avoiding adhesion and the tendency for scarless surgery in young women. The most important surgeries about endometriosis, ovary torsion, diagnostic laparoscopy, tuboplasty, salpingectomy, PID, release of adhesion, gonadectomy, Mullerian anomaly. Moreover, laparoscopy is golden standard for ectopic pregnancy and some situation like intrauterine device that perforated the uterus and be in the pelvic cavity or abdominal cavity. I started my discussion with a short review about endometriosis. All you know, endometriosis is very common, challenging disease with wide diversity in presentation, and treatment is a combination of the medicine and the surgery. For management of endometriotic patients, we have to remember the essential rule of medicine, and it is very important in endometriosis. First, do not harm, because no treatment is better than wrong treatment, especially in endometriotic patients, and unindicated surgery is really harmful. Before surgery, ureter involvement must be diagnosed, because the only definite reason for laparoscopic surgery for endometriosis is ureter involvement, and if we miss that, we don't have anything for the patient. Endometriosis is not only ovarian cyst, and removing the IE is really important, and emergency situation is rare in endometriosis, only maybe in some case of rupture of cyst and bone perforation, that is really rare, and I saw only in case reports. Malignancy is rare in endometriosis, and we don't surgery for endometriosis because of malignancy without any evidence of the surgery. We can start the video. This is one case that the uncommon situation for endometriosis, the emergency situation in endometriosis. As you can see, it is the perforated cyst, and the chocolate material covered the pelvic cavity. She was 27 years old patient, newly gravida with right endometrioma. Because she had not really pain, I kept her on under observe, but suddenly she complained from sudden pain and tenderness, and ultrasound show us mild free fluid in the pelvic endometrioma was perforated. Although it is emergency situation, we can prepare the ovary cystectomy and salpingo-ovariolysis done for her. And at the end of surgery, the normal anatomy of pelvic can feasible for her.
Disconnect. No, it's coming. Yeah. You can go next.
Another situation that we prefer to manage by laparoscopy is torsion of ovary. Torsion is real emergency. We have some difficulty on diagnosis, and sometimes patient is baby or in the adolescence, and they and their parents reject surgery. But when we prefer laparoscopy for her, maybe they accept easily. Torsion sometimes is because of the ovarian cyst, like this patient. That semi-torsion occurred because of the large dermoid cyst in the 16 years old girls. Although before that surgery, I scheduled her for surgery, she rejected because she told, I googled, it is benign and I want to wait. But one time she had a severe pain and scheduled for emergency surgery. Fortunately, semi-torsion occurred and the discoloration of the ovary doesn't occur, and we can do the cystectomy for her. The thing that is really important is the large dermoid cyst is not indicated for laparotomy or for oophorectomy. We can do cystectomy for all type of benign ovarian cysts, like dermoid, large dermoid, without damage to the ovary, and preserve the ovary. And the size of cyst is not indication for laparotomy. Even if the perforation is done during the surgery, we can manage by suction and avoid turning in the pelvic cavity or suction. That, as you can see in this, we can manage this situation without any complication. And at the end of surgery, the ovary repaired and we can preserve the ovary. And this is the voice. How we can off the voice?
It's okay, doctor. Good to have some audio effect as well.
Okay. Not a common, but some challenging situation. This patient inserted the IUD 3 weeks before in follow-up ultrasound. IUD was placed above the bladder. If our approach was laparoscopy for this case, midline incision had to be made, and sometimes we have big challenge for found IUD. Sometimes when we want to remove the IUD because of overreaction response to copper and severe adhesion, bowel perforation or bladder perforation may be occurred. But with laparoscopy, we have a good view for finding the IUD and manage this patient this time. And another situation that is really challenging for a young patient, especially in the infertility cases, is about the pelvic inflammatory disease and hydrosalpinx. This patient is a 38-old woman with a history of 18 years, primary infertility, 2 times IVF failure, and bilateral severe hydrosalpinx, scheduled for salpingectomy before last transfer. She had only 2 embryo, and it's the last chance for pregnancy. As you can see, there is a severe adhesion between the uterus and the rectum, and both of the adenoids are severe adhesions to the rectum, and the tube retroperitoneal. This situation maybe made some difficulty, for example, bowel perforation during the surgery, but laparoscopy offered this better view than laparotomy for us, and we can release the tube and ovary and do only salpingectomy for her by preserving the ovaries. And at the end of surgery, we can normalize the pelvic anatomy. You can see this is the left tube, right tube that we retroperitoneal on, and after release of adhesion, we can find the tube and done the salpingectomy for her. In some cases, we have more consideration about, we need to some consideration about the scheduling patient for laparoscopy. All of this that I show here, myomectomy, hysterectomy, cystectomy, metroplasty, niche repair, scar EP, any type of surgery during pregnancy, we can do laparoscopy in this patient, but we have to select the patient. For example, for large myoma, large uterus, maybe have some difficulty for delivering the myoma or the uterus, but we can do that in some cases. This case that I want to show you, this is the very large cyst and abnormal stature. This patient is 28 years old, there is no case of achondroplasia, very obese, BMI about 15, and she had a large ovarian cyst. As you can see at the first video, this cyst filled all of the pelvic cavity and under more than umbilicus level. I entered from halfway point, but the cyst is really large. This patient, because of her problem, afraid from surgery because of concern about anesthesia, overweight, positioning, and something like that. But when the cyst became larger and larger, she accepted the surgery when I prefer the laparoscopy for her. We have some difficulty for this case about anesthesia, positioning, transfer the patient, and her assessment take a really long time, more than 1 month for cardiac consult and anesthetic consultant. But fortunately, we can do laparoscopy cystectomy for her. As I mentioned, the large cyst is not indicated for laparotomy or not indicated for oophorectomy. In this patient, we can preserve the ovary and repair the ovary, and the patient can discharge it the morning after the surgery. This is that patient, and her smile worth all of the difficulty that we suffer from this surgery. Frozen and permanent specimen shows serocystadenoma, and fortunately we can save both ovary for her. And about the myoma, as I told, this is a really large myoma. You can see this is the myoma and this is the uterus. This is a really large, more than 20 centimeters myoma. Although if we want to do completely laparoscopy for this surgery, we have to use morcellator, but because of some concern about the malignancy, we don't like to use the morcellator, and we excise this from a mini laparotomy 2 centimeters and morcellate by knife without electronic morcellator, and at the end of surgery we can save the uterus and do not laparotomy for her. And about the hysterectomy, as we all know, hysterectomy is one of the major surgery that a patient is scheduled for because of some problem like bleeding, myomatous uterus. The thing that is really important, that large uterus and myomatous uterus can be done by laparoscopic, but by some consideration. This patient is 44 years old, to produce LSCS, large myomatous uterus more than 14 centimeters, complaint severe abnormal bleeding, scheduled for a laparoscopic hysterectomy. As you can see, we have some difficulty for dissecting the bladder, but it is feasible. We can use ligature for ligate the uterine artery, and
the uterine manipulator for dissecting the uterus from the vagina, and at the end of surgery we can suture the vaginal cuff. This is surgery done 2 weeks ago in Starcare hospital in Barka, and although the uterus is really large and myomatous and have 2 previous surgery history, we could and we can discharge her the day morning after surgery. And this case is
The mic is not working.
This case is a case of coronal pregnancy. This abnormal implantation occurs in a very high risk serious hemorrhage owing to the greater size of the ectopic pregnancy and rich vascular, but these patients normally scheduled for laparotomy because of the risk of severe bleeding. She was a 34 years old woman with a gestational age of 7 weeks, history of 2 LSCS, suspicious to ectopic pregnancy with lower abdominal pain, and ultrasound showed us about 5 centimeters ectopic mass adjustment to the uterus. Because of the possibility of severe bleeding, we have to use the technique for decreased bleeding, like vasopressive injection or uterine artery ligation. And sometimes the bleeding may lead to the hysterectomy for this patient, but fortunately this patient can manage this patient laparoscopically and save the uterus and both tube and ovary for her. And this surgery have done in Starcare Hospital, Barka, about 1 month ago, and fortunately we can save the uterus and both tube for her. This is the ectopic mass, and at the end of surgery, then we save the uterus and both of ovary and tubes. And I had a short discuss about the hysteroscopy. Hysteroscopy is a different word. Hysteroscopy can be really useful, especially for I want to tell me about 2 types of hysteroscopic surgery. This is the hysteroscopic myomectomy. All gynecologists know that the submucosal myoma made really some difficulty for the patient. Hysteroscopic myomectomy is golden standard treatment for submucosal myoma, especially 0 and 1 type. Actually, in correct scheduled cases, it can be amazing because we can solve big problem with simple, fast, outpatient, non-complicated procedure instead of hysterectomy. For example, this patient is a 40 years old woman with 10 centimeters submucosal myoma, 0 type, very severe and continued bleeding, severe pain during bleeding, and multiple history of transfusion because of severe anemia. She afraid of hysterectomy, and when I scheduled her for hysteroscopic myomectomy, of course, with the consent of possibility of hysterectomy, she accepted, and we can remove this type of myoma by resectoscope most of the time. You can see this is a really large, more than 10 centimeters submucosal myoma, and this was intracavitary and made severe bleeding for her, but we can preserve the uterus for her. And another type of hysteroscopic surgery is for uterine septum. Uterine septum is the more common uterine anomaly related to recurrent abortion and can be managed simply by hysteroscopic method. Sometimes recurrent abortion lead to recurrent DNC, retained tissue, and patients become more complicated because of the uterine synetia. This patient was full gravida without any lip child, that first pregnancy, preterm delivery and bridge done the LSCS for her, then the abortion. Because of the care incision in the lower segment of uterus, we started the septolysis from this incision. Otherwise, as you can see here, she had a common isthmus because of the care incision of before LSCS. Otherwise, if it's a long septum, she had two vagina and two uterus. We can take the balloon here and start the septolysis at the lunging point. But for this patient, we started the septolysis from this incision, and the unification of the uterus kind of, it's not really difficult, but it's really important for pregnancy. Thank you so much. Thank you for hearing me. I hope
Thank you, Dr. Parnian. Of course, she deserves a big hand. We will reserve some time and then end for some discussion, I think. We'll proceed to next talk. We have now a very experienced, eminent personality in surgery, Dr. Habeeb Mohamed. He is my colleague in Starcare Hospital, Barka. He is a very senior laparoscopic surgeon with a lot of interest in proctology, and his key skill, as you can see there, is the laser, application of laser in proctology. I invite Dr. Habeeb to deliver his speech.
Assalamu alaikum. Good evening. I'm Dr. Habeeb. I'm specialist in general and laparoscopic surgery at Starcare Hospital, Barka. My topic is the impact of laser on modern proctology, and including my experience in laser and conventional proctology. As Dr. Submaran has introduced me, I started as a general surgeon, and my interest went on to laparoscopy, minimal access surgery, and further into the natural progression, further into laser, where there is even no incision. Proctology, as you may assume, involves treatment of hemorrhoids, fistula, fissure, and pilonidal sinus. As you might have noticed, there is one condition which is conspicuous by its absence, that is tumors of the rectum and the anal canal, which I have avoided in this talk because they are not managed by laser. And I have included one more thing, that is pilonidal sinus, which is not exactly a proctological condition, but most common men consider it as a proctological condition and come to you for treatment, and it can also be managed with a laser. So I have left out tumors and I have added pilonidal sinus in this talk. Fistula in ano, as you can see, is a very tedious condition, very troublesome problem for the surgeon because of its recurrence. It recurs again and again and again. And the treatment options are fistulectomy, fistulotomy, lift, laser, and latest is BART. Fissure in ano is a very painful condition, and usual treatment options are fistulectomy, sphincterotomy, Botox injection, and laser. Pilonidal sinus, as I told you, is another condition where excision and flap, laser and exit are the treatment options. This is the excision and then excision with flap, then is Z-plasty and the limber flap, all done in Oman. And the most common proctological condition, that is hemorrhoids. It is the most common anorectal condition, and about 50% of the population is affected in their lifetime, and about 5% of the population is affected at any point of time. The pathophysiology can be venous, arterial, connective tissue and muscular. Understanding the pathophysiology is very important because it gives better results if you understand the pathophysiology and then give the appropriate treatment. Management, we start with dietary and lifestyle modification. Then the medical management includes micronized purified flavonoid fraction MPFF. Then there is rubber band ligation, injection sclerotherapy and infrared coagulation. These are daycare surgeries, not outpatient surgeries. Milligan-Morgan hemorrhoidectomy, which is a classic surgery and a very painful condition, and logo staple hemorrhoidopexy, painless and like a minimal access surgery. And then we have laser. Laser is light amplification by the stimulated emission of radiation. Different kinds of laser are there, and the effect depends on the wavelength. And as you can see, 980 and 1470 are the most common wavelengths used for proctology, because 980 is absorbed more in hemoglobin and blood, and 1470 in water. But as you can see, carbon dioxide laser is more absorbed in water, actually we don't need carbon dioxide laser for proctological conditions. I will explain a little later. And the effect depends on the temperature. Less than 40, above 40 degrees centigrade, there is enzyme induction, membrane disintegration and edema. 45 to 60, there is tissue damage. Above 60, there is coagulation. And above 100, there is dehydration, carbonization and vaporization. It is this above 60, that is coagulation, that we require for laser proctology. And this is, as I have mentioned earlier, this is the effect of laser. On the right hand side, you have the carbon. We have our 1470 wavelength, and this is the carbon dioxide. On this side, this is the carbon dioxide laser. As you can see, carbon dioxide laser cuts very sharply with very minimal tissue reaction on either side, and our 1470 laser cuts bluntly with a wider area of tissue reaction, and that is what we require for proctology, not a sharp cutting. Sharp cutting may be useful in fine surgeries like in ophthalmology. So we don't need that, we need the other one with a blunter cut and a wider tissue reaction. And these are the types of fibers. As you can see, there are two types of fibers. One is a radial fiber, which has a radial or round corona, and we have a normal bare fiber which has got something like a torch or a matchstick, where the only one point is point of ray is used. And this is my own data for the last 3 years. Total number of cases is 289. And this is the split up conventional. Even in conventional, it's not, if in hemorrhoidectomy and all, it's not longo step, it's not classic hemorrhoidectomy. It is either staple or hemorrhoidal artery ligation with rectoanal repair. More towards the minimal access and less painful situations. And you can see I have done 72 cases of conventional surgery and 217 cases of laser, totaling around 289. And the results show that in hemorrhoids, 80% of the patients choose medical management. But in fistula, pilonidal sinus and fissure, about 80% choose surgery. The mean age was 41 years, that is, younger population is more affected, but the minimum was 13 and that was a pilonidal sinus, young girl, and a maximum was 87. That was a male patient, an old baba with all comorbidities, cardiac risk, medical risk, everything. The male-female ratio was approximately 3:1, 219 male and 70 female. The average hospital stay of, I'm talking about laser now, hemorrhoids and fissure in ano is about 8 hours, pilonidal sinus about 12 hours, and fistula about 3 days. That is not because there is pain or morbidity. I want in fistula, I don't use the laser alone. I combine a lift with a laser. So I close the internal opening by open surgery. I lift, go through the intersphincteric space, close the internal opening, and then the track is dealt with by laser. And I don't want the intersphincteric incision to be infected, so I keep the patient ill by mouth for 3 days, so that by 48 hours the upper layer is closed and then chance of infection is lesser. And post laser return to normal routine. There are people who have, there was a patient from Sohar who drew from Sohar to on the same day of surgery, from Barka to Sohar on the same day. And there is hemorrhoids and fissure, the average is 5 days, pilonidal sinus 7 days, and fistula around 14 days. The complications include thermal injury to mucosa and internal sphincter, hematoma and clot formation, postoperative bleeding, infection and perianal abscess, pain and recurrence. Contraindications, there are no major contraindications for laser in proctology. Concomitant local malignancy may be a contraindication, not malignancy, because I had 3 patients who expired within 3 months, but their main problem was bleeding from the hemorrhoids, and laser had given them a very big relief because there was no more bleeding, the mass had reduced, and they were very happy, even though they knew that their life expectancy was very low. There were 3 such patients, but that was not contraindication. Actually, it was a benefit for the patient. And anesthetic complications and other general conditions. So, laser treatment of fissure in ano, hemorrhoids, fistula, and pilonidal sinus has the advantage of lesser operating time, lesser skin trauma, resulting in lesser pain, lesser hospitalization, and a quicker return to work. Laser treatment has the option of general anesthesia, spinal anesthesia, or local anesthesia with sedation as a method of anesthesia. Laser treatment has comparable results with regard to relief of symptoms and recurrence when compared to conventional methods. I would like to specify the role of non-surgeons, especially GPs, physicians, and gynecologists. As most cases of fissure in ano, hemorrhoids, fistula in ano, and pilonidal sinus may first approach a general practitioner, physician, or a gynecologist. Especially in Oman, female patients may approach a gynecologist first. Conservative treatment can be tried in the case of hemorrhoids and fissure in ano for up to 3 weeks, and may be referred to a surgeon if conservative management fails or illness recurs. In case of fistula in ano and pilonidal sinus, it's always better to refer the patient to a surgeon at the first instance itself, because there is no role for a medical management except pain relief or antibiotics, which are not permanent. Once the antibiotics are stopped, the infection will recur again. And in conclusion, if medical management alone is not effective, laser is the most suitable first-line treatment method for most types of hemorrhoids, fissure, fistula in ano, and pilonidal sinus. Laser has made the treatment much more quicker and easier for both the surgeon and the patient. Stapler and conventional methods of management still have a place in the treatment protocol in selected cases. And video assistance, as in WAFT and EPSIT, is a helpful tool for treating fistula and pilonidal sinus under vision. especially in recurrent cases and with side tracks. And a picture is worth 1,000 words. This is, as I told, the oldest patient, 87-year-old Baba with a grade 3 hemorrhoid. And this is the pre-laser, and then that is the post-laser. I have not even removed the sheets, and the effect is immediate. And this is the worst case that I have managed with laser. A grade 4 hemorrhoids, bleeding, patient cannot sit, could not sit. This is a pre-laser and that is a post-laser. And the same patient after 3 weeks. And this is our team, OT team, including our medical director, who is also my colleague surgeon. And I am conspicuous by the absence because I took this photograph. Thank you. I would like to show you a small video. Unlike Dr. Parnian, I cannot impress you with the videos because it's a very small area. You need professional videographers to shoot the video. But the one I could get, I will show you a laser. And as you can see, if you notice, this is the laser inside. As you have seen, I pointed towards the mucosa, but the red light should not be that obvious, because if you are too close, then the red light is seen, and if you are, it should not be that close so that you burn the mucosa. This is the right depth or plane through which you should go. And the laser is used to, all the septae are divided, burned, and it is made into a single cavity, and the blood is boiled so that there is burning of the inner aspect of the mucosa, and it adheres to the internal sphincter. So that there is actually a PEXI, addition and PEXI. Thank you, and sorry I could not provide a better video, and thank you all.
Thank you, Dr. Habeeb. It was very brief, but as you could see that. So, we have all been treating hemorrhoids conventionally for a long time. We all know, I don't think anybody will differ with me when I say that effective treatment has been more terrible than the disease itself. It takes weeks or months for the patient to be relieved from the symptoms due to surgery as well. That is where I would like to reiterate the point which Dr. Habeeb. Incidentally, our first patient in Barka, Starcare Barka Hospital, who underwent laser was from Sahara. He, as Dr. Habeeb rightly said, he was admitted in the morning. Before noon only the surgery was done. By around 4 or 5 in the evening, we planned to discharge the patient. We were worried the patient was alone, but the patient was challenging us. He wanted to drive himself alone back to Sohar. So that is the difference which the laser has made in proctology. Now, we will move on to the next speaker. He is a special guest for us. He is a very eminent surgeon, laparoscopic surgeon, general surgeon, and proctologist from India. He is none other than Dr. Rajeev. In fact, he is one of the pioneers of the so-called WAFT, video-assisted fistula therapy treatment in India. Thank you, Dr. Rajeev, for being present here. We are all waiting to hear from you. Thank you.
Good evening. Thank you so much, first, all management and chairperson from Starcare, Barka, and Dr. Alfred and Jayram for inviting me here today. So, I'm from a place called Bangalore in South India, and we are the IT capital in India, and you know why we have a lot of problems. So anyway, to start with, I'm just going to touch upon two important advances. And first is WAFT and EPSID. I'm not saying that they're the only surgeries, but definitely they are in the future, and they already started becoming very popular. So first and foremost, I don't have any disclosures here. We all know what's a fistula. It's just a blind ending tract. From Latin, fistula means pipe, and it just connects an epithelial surface to a mucous surface, and it never dries up because of the fact that the bowel keeps going through. So we have a lot of options there, but before you deal with a fistula, please make sure you do an MRI scan, a fistulogram, and always ask for a colonoscopy before you send the patient to the surgeon or let the surgeon know that he needs to do it. I'm sure the surgeon will do it. Because a lot of comorbidities associated with fistula, like IBD, ulcerative colitis, even tuberculosis in our country. But once you do that, you know the anatomy of the fistula. And once you know the anatomy of the fistula, we surgeons, we want a GPS map, and that's our GPS map. Most fistulas are low fistulas in literature and also in our practice. 75 to 80% will be well served with a simple fistulotomy or a fistulectomy. What happens when we have a higher fistula? A fistula which is suprasphincteric, going above the sphincter, or extrasphincteric, what do we do then? We all know that, sir has already spoken about laser, but we also have sit-on, which is being done for many years. But the main problem with the fistula, which is high, is incontinence and recurrence. These are the things that we need to really address. Simple fistula, please make sure that you make good friends with the radiologist, ask him to draw a diagram and show you, so that you know what exactly is happening. I always do an MRI because it makes sure that the anatomy there and we know what we are dealing with. Inject some ethylene glue, put a probe through, the simple fistulotomy, and it's done, and you send it for biopsy. Or you always infiltrate local anesthesia. Now we have Robocaine, which is so nice that the patient can just go home as an ambulatory surgery. But what happens if you have high fistula, something like this, which is going right above the sphincter? Get the anatomy right, speak to your proctologist, speak to your radiologist. I'm sure they'll do a great job once they get tuned to what you want. This is an MR fistulogram which my radiologist always sent. So my radiologist here now has become very famous fistula radiologist in Bangalore. So he doesn't want to be known by that, but unfortunately he has. But today let's discuss about WAFT, Video Assisted Anal Fistula Treatment. It started in 2006. It's not a new procedure, but it got published only in 2011. And the first person who did it, Dr. Minero, is from Italy, and he actually invented the procedure. So the scope goes with his name, Minero Fistuloscope. It's a normal scope, but the fact that it's a small scope, it can connect into your regular laparoscopy equipment. So the investment is not much. It connects into your laparoscope, and I use Olympus, and this equipment is made from castors, easily compatible. It has a long sheath, which is about 18 centimeters, 15 centimeters working channel. It has a washing thing. It's just like our hysteroscope. Many of the instruments I share with my gynecologist. I have a 2 millimeter hysteroscope biopsy forceps going through this. It has an operating channel. I can put a forceps or brush, things like that. And the washing channel I borrow from my urologist, and then it connects onto my laparoscope. So very simple, not very expensive, and the whole setup will not cost in our country less than 5 lakh rupees. So there are basically two phases. The main advantage of that is that you do everything under vision. So you know exactly what you're doing. So you have a diagnostic phase and you have an operative phase. In the diagnostic phase, you know there's the external internal opening there and external opening here, and you pass the scope through and you get the vision. And I'll show you what it means. You use glycine mannitol, like the urologist, and negotiate down to the fistula to the internal opening. And you go and find the internal opening. And once you identify the internal opening, you put a circular stitch there to make sure you identify that area. It's not required that you read. Sometimes you don't even find it. You just see some fluid coming out, but you know where the internal opening is. And then you go into the operative phase, where you go and destroy the granulation tissue in the fistula tract. And once it's destroyed, then you go ahead and seal off the internal opening. The methods to seal the internal opening are down there. So this is the actual surgery, and you can see the old perilapse has been scarred, which has been drained. You enter and you can see the water, the glycine mannitol coming through that area. You can actually see that there. So you know definitely that there is an internal opening at some drop position which you can mark. This is an anterior fistula, and all of you remember Goodsall's rule: anterior fistulas are straight and posterior fistulas are usually horseshoe shaped. And with the pressure increasing the glycine, which you can actually see the fistula opening internally there. So it's not difficult to find the fistula opening. And then you isolate the fistula opening. And this is how a fistula tract would look. This is my scope, the fistuloscope, which I told you is just about 4.7 millimeters into 3 millimeters. It has a slight 80-degree angulation. The laparoscopes understand that, and that helps you to identify the fistula tract. Once the tract has been identified, the diagnostic phase is done, and then you go and destroy the tract with a monopolar cautery. A probe is passed through the fistuloscope and you destroy the entire tract. And once the tract is destroyed, you can see the granulation has all gone away, and it now begins the bed for it to heal. The biggest advantage of this is its under vision. Therefore, if you have a branch, you can turn around the scope and see the other branches, which makes the success of the surgery much better than a blind technique. That's the thing. Initially, we were using staplers, but now that we have a special suture which has barbs in it called V-lock, we go ahead and use V-lock to close the suture, close the internal opening. And you can see the stapler line. We also were using glue, but of late I've stopped using glue and I don't find any big advantage. We just extend the external opening a little bit so that it drains out well, and we use a tampon there, a stone tampon. So the main thing is that it's a minimalist technique and you do it with direct vision. There are surgeons, and I've already begun to see papers which they combine WAFT with laser, but we still have we need more data to understand that. You can exactly find the internal opening. You can find the branches and you can then destroy it under vision. There's no sphincter injury because you're working inside the tract, you're not working inside, and there's unlikely chance that you'll go outside the tract. As soon as you go to the tract, you know, like in the beginning of your career, you begin to see some fat and then you know you're on the wrong path. Very less pain, most of them are ambulatory daycare surgeries, and there's hardly any dressing. The best part is that you can even repeat it if the patient is alright. The success are about 75% in WAF. That's the international statistics. So that's Professor Minero. Anyway, now I'll just go on and jump to the next topic, which is EPSIT. It's quite late in the night, so I'll just go a little faster, but you can always discuss over dinner if you have any questions. The extrapolation for the same fistuloscope is in pilonidal sinus. And this is how a pilonidal sinus would look. And we all saw how the mobility of pilonidal sinus excisions are and flaps are. But you can use the same equipment, the same fistuloscope to deal with the pilonidal sinus. So again, you have a diagnostic phase. Here I do not show any animation, but go directly into the thing. This is a simple fistula, simple pilonidal sinus with just 2 openings. I would just take some peroxide and just infiltrate there. And you know where it's going through. You can pass the fistuloscope and you can see the high pressure glycine opening of the entire tract, and you can actually identify the entire tract completely under vision. So you can see how does the tract look, pilonidal sinus? You can see the hair inside the sinus tract. And you can go and use the forceps to pick out each of these bits of hair. You can clean up the debris and you can make it a clean tract. You can see this is a 2 millimeter forceps, which I borrow from I have one, but I will definitely borrow if I need to. And take out all the debris. And after the debris is removed, you can go and destroy the entire tract with the same monopolar cautery. This is all reusable equipment, so really there's not much of consumables here. That's how the granulation is destroyed. And once the granulation is destroyed, you have a tract which is devoid of granulation and debris is all cleared off. So we can do this under local anesthesia. We infiltrate xylocaine adrenaline with ropivacaine, which is a very nice long-acting local anesthetic, and we use it pulmonary sinus, and you can do it just like an ambulatory surgery too. At the end of surgery, you have the small wounds which just discharge, and we teach the patient's attendant to just infiltrate saline into the wounds right from above and below, and end of which about 3-4 weeks the wounds are all dry. So just like in VAP, it's a minimally invasive technique, but it's under direct vision. There's no lateral injuries, so that's very good, and it can be done on local. There's very less pain. There's minimal dressings, and you can send the patient home very quickly. It can easily be repeated. If you have a few minutes more, I'll just show you an interesting case. This was a security guard, He turned up with a non-healing wound in the belly area. We all think that it's a fistula most likely. And he only gave the history that he fell on a bamboo fence about a month before. And he had gone on multiple surgeries for abscess and so-called fistulas and everything, but he had no relief. The only comorbidity was he was a diabetic. And this was the examination, and the MRI was really inconclusive, and we really couldn't find out the fistula as such. We have a good radiologist, as I told you, so he was able to find this tract going up. And he said, it's not a fistula, but I can see some wooden spicules possibly there. I don't know how he made out this wood. But we could see, you can see these floating particles there. And then I said, okay, I have this fistuloscope, let me go inside and see what's happening. So that's the operative picture where there's an opening there, and then we went through the tract. And we went inside, we could see the wooden spicules. So the bamboo thing, fence on which he jumped, actually broke and shattered those pieces, and he got into the sinus tract. And we could see all this. And what I did was I used the forceps to go and remove each of these bamboo bits, and we could take it out and clear the entire tract. So it was very satisfying to do this surgery, because this guy, we didn't promise him anything because we didn't know what was happening, but he recovered within a month, and it was very nice to see him do it. But I always say, all surgeries don't need the best technology. Sometimes good old stuff, good old hysterectomies will do the job for them. So when it's new technology, be careful, it may turn around right. So let the surgeon decide. Thank you.
Thank you, Dr. Rajeev. We have been so fortunate to have you here today evening. It was very interesting, very informative, and especially thanks to Dr. Alfred. He is our consultant surgeon. He is instrumental in bringing him here today. And thank you, and a big round of applause for Dr. Before Dr. Sadiq comes in, I think I will request Dr. Alfred to please come on the dais and speak a few words, actually, not on the time.
Thank you, Dr. Sukumar. Congratulations to all the speakers. I think it was really good. You all spoke so well. I just want to say that proctology, when we set up a proctology department or a unit, we need to have all the equipment in the department, in the unit, and then we need to tailor the surgery depending on the patient. We do not try and use one technique for all the patients. There is still a good number of patients who would benefit from conventional surgery. We must keep that in mind. We must use newer technology to help the appropriate patient. Especially with the newer minimal access techniques coming, the advantages to the patient are tremendous in terms of post-operative pain, in terms of recurrences. But please remember, all these techniques will always be compared with the old gold standard techniques, so we must be aware of this. I want to re-emphasize that we will tailor the treatment to the patient. We do not promise the patient when he comes that we will do X technique or only laser or only waft. Depending on the patient's pathology and his stage of disease, we will decide. That would be a much better way to approach all these proctology problems. Since we are running late, thank you, Dr. Kumar.
Thank you, sir. No surgery can happen without anesthesia. And today, we have been really fortunate to have none other than our beloved chairman of Starcare Group of Hospitals. He was a consultant anesthesiologist also, to speak a few words.